Hi folks, my name is Dr. Alan Matthews. I am a dentist working in private practice in Edinburgh, and I've put together a really short presentation here on day-to-day occlusal principles for the general dental practitioner. The point of this is supposed to be really simple stuff, not getting into mega in-depth stuff to do with occlusion, but some simple principles that you can apply when you're looking at wear and tear cases or you're looking at failure, trying to work out what's happened and trying to work out how you can prevent that failure moving forwards. So, here we start with a really common scenario. Someone's come in, they've got a tooth with a particularly large restoration in it, and something has broken off. Is this enough? Can we just stick a little bit of composite onto the broken piece and expect it to work? Maybe, sometimes, but sometimes maybe not. If we look at how the break happened, what we can see here is when this person slides their jaw to that direction, there's wear and tear to the tips of the canines. And because of this, the teeth towards the back are also involved in this sideways slide. What we should keep in mind is that when it comes to the way the force is distributed in the jaw, the nearer you get to the hinge at the back, the higher the force will be. If you want to crack a nut, you put that nut in the hinge of the nutcracker. You don't put it between the levers towards the end. And similar principles apply to the jaw, which is, at the end of the day, a hinge. So if we want to try not to have very high forces moving laterally through tissues towards the back, we want to try and move that guidance more towards the front if we can. So when we look at this solution, not only was the top tooth restored with just a little bit of composite, I added a little bit of length to the canine down at the bottom as well. And what this did was it maintained the same bite in maximum intercuspation, but when that person slid to the side, the extra little bit of length on that bottom canine meant that it separated the teeth towards the back. What that means is that the teeth will be loaded much and such the same when biting together, but on sliding sideways there'll be a reduction in force and an unloading of vulnerable teeth that may otherwise chip or break off again. So we talk a little bit about anterior guidance. You may hear people talking about canine guidance or group function, and really what we're thinking about is, what does this actually mean? What it means is when the jaw moves side to side, it's what teeth are involved in that motion. And this is something that I build into every checkup that I do, because you can see an enormous amount about how teeth get worn, how teeth get damaged, how teeth get chips on them, how they get flattening of them, how cracks start to develop, if you just have a little look at what the jaw is actually doing mechanically. As I've already used the nutcracker analogy, the further away you get from the hinge, the lower the force. So what teeth do you maybe want to put the guidance on if you're looking to reduce the force? Ideally, you would have broad, flat surfaces with shallow guidance that these can pass quite gently across each other, distributing the load really nicely. If you have two incisal edges, nothing wrecks enamel like more enamel. If you've got those thin edges hitting off of each other, what you will ultimately end up with is a flattening of those sharp edges into something a lot smoother and flatter. So can incisal edges support guidance? Depends on the amount of force that's going through things, but if avoidable, I would choose not to use them for that purpose. So, as I showed you in the case before, what I did was I raised a canine, effectively created what we call a canine riser, in order to influence the guidance in such a way that we were unloading the back teeth. So you might think, great, just do that for everyone. It isn't always possible, unfortunately. If someone's canines are in very poor condition, you don't necessarily want to start getting that tooth to do the majority of the work, because you don't want to see something break or fracture, and removing a canine is a nightmare. Never mind trying to replace the thing. Class 3 skeletal bites, or class 3 skeletal base, that is, when someone has a bottom jaw that is larger than the top jaw, you will generally find that their back teeth do most of the guidance. And if you were to try to create canine guidance in such a case, you're going to have to make mammoth canines for that to work. And realistically, the mechanics just aren't there. A locked-in bite. Locked-in bites, these tend to be class 2 cases. These are examples where you've maybe got quite steep inclines. If somebody's canines are tipped a little bit more inward, what you tend to find is that sliding motion side to side, they'll quite quickly crash into a very steep canine, and rather than being able to move smoothly up that canine, what tends to happen is they get locked in. If you've ever done an occlusal checkup on someone and you've asked them to slide side to side, what you will often find in these people is they just can't do it and their head goes. So they turn their head or they move their lips around, not really able to move their teeth at all. And then we often have things like deep class 2 cases. If someone has a very, very deep class 2 bite and you try and add just to their canines to influence the way they're moving around, odds are you're going to make those inclines steeper and you're just going to create somebody who's locked in. So when you can't raise the canines or you can't get more of an anterior guidance, what you aim to do is to try to have that guidance as far forwards as possible so the force going through things is less. Try to keep the angle of motion shallow so you're not having to slide up a cliff face. And you want to try and have nice broad surfaces touching if possible, and ideally not kind of knife edges that are sliding across each other because they're more likely to chip and wear and break down. Again, similarly with incisal edges, you don't want to destroy those thin tips to the incisors by having them scored across each other. And where you can't create the anterior guidance, you want to make sure that you've made sensible decisions with your restorative work on back teeth. Make the back teeth strong, make the front teeth smart. If the back teeth are getting slid side to side on, the last thing you want is to put a colossal MOD composite in one of those teeth and allow the opposite teeth to slide on and off the composite and up that steep wall, only creating more of a situation where you're going to break the wall off that tooth. How many molars do you see where that's exactly what's happened if you took the time to have a look and see what's going on with the bite? Similarly, you don't really want to have too many scenarios where you're going from tooth to restoration and back, because what will happen is you'll have enamel, the hard opposite enamel, sliding from tooth to restorative interface to restoration and back, and that restorative interface is the weak spot, which will begin to degrade as that happens and ultimately start to break down and fall apart. Always sensible to be wary of big restorations when you're not able to control the guidance in the same way, and be very vigilant for cracks. If you're looking at someone who is, for example, a class 3 case and they've got cracks in their molars, you want to be treating those because those teeth are the ones that are going to be in lateral excursion and the force going through them is going to be much, much higher. Keep in mind though, you don't just have to put onlays and crowns on every tooth in someone in a class 3. Nobody died from having an inappropriate occlusion or from having a class 3 occlusion or from having a class 2 occlusion. It's just important to recognize risk factors and to try and identify when something needs your intervention. A couple of straightforward rules when it comes to doing a little bit of bonding to change the guidance. Remember, bond is best to freshly cut enamel. You want the end of those enamel prisms if possible, not the disorganized fluoridated surface. And it's not a bad idea to consider using a red banded burr to just do a little bit of prep of that surface. You cannot bond to spit. Clean that spit off. Using something like a micro etcher is a really good idea, something along the lines of 25-27 micron silica, just to blast off any saliva from the surface so you've got a nice clean substrate to bond to. Avoid excursion on restorative interfaces. Now, we have talked about that, where we don't really want you going from tooth to interface to restoration and back again, because that is something that will degrade an awful lot faster. If that means extending your restoration to the point where they occlude on the restoration and slide back and forth fully on the restoration, that is sometimes a better way to go. You don't really want somebody, for example, where you've done a 3/4 veneer and when they bite together on tooth, but as soon as they move their jaw, they're sliding across that margin that you've created, because that will start to open up as time goes by. Investing in materials is always sensible. It is such a false economy to scrimp on your bond or to scrimp on your composite materials to have things with low filler just because they're cheaper. What you will only end up doing is doing them multiple times. It's better to be looking at materials that bond really, really well and materials that have a good filler content and good properties that mean that they can put up with the forces in the mouth. You know, there are There are examples of human jaws being able to exert half a ton of force, and that is going to be immensely destructive if you haven't put something that is reasonably strong in there. And then, of course, you've got to tell people regular maintenance of this type of thing. I consider something like a canine riser, when appropriate, to be something more of a consumable, meaning that if they chip or break off that little bit of composite every now and again, that is a lot better than losing tooth structure, and it generally means that all I have to do is replace a little bit of composite. And if they're prepared for that and they understand that that's what the long-term thing is likely to be in order to keep the rest of their teeth healthy, that's something that people can accept at a much earlier stage, rather than you telling them after it's happened. So, failure. It is important to talk about failure. It's important to prepare for failure. If you do not prepare for failure, then you can expect things to happen that you hadn't considered. Remember, if you advise someone beforehand, that is an explanation. I have built up your canines. Over time, you might chip off these little bits of composite that I've made. That's okay. That stops you from breaking tooth structure, and I can replace the composite. Rather than advising them afterwards, because that becomes an excuse. Oh, that canine riser I built up, that was always supposed to be a consumable. It's okay, we'll just replace it when that happens. Do you see the difference? In the beforehand, that person is prepared and likely willing to pay for the replacements. In the other, what you will likely find is that person will expect you to replace it for free ad infinitum. So it's important that you have the correct level of communication at an early stage. And on to communication, you must make it clear that these things need to be reviewed and renewed at regular intervals. They need close maintenance. It is the dentist who needs to be looking at these and seeing early failure and managing that at an early stage, either with a little bit of tidying up or replacement of the composite, to make sure that they don't have something catastrophic happen. It is our job as dentists to help our patients get worse as slowly as possible. Entropy is a thing. Everything degrades. However, if we can prevent that degradation as much as possible and slow down that type of thing, then we can expect that moving forwards, our patients are going to be well served and they're going to lose a lot less tooth structure. As I've already said, renewing a chipped addition is always much better than losing tooth structure, but there can be other variables that you need to control. It's not all about how the teeth meet. There can be things like acid reflux, which you may need something like a proton pump inhibitor. I'll tell you about ways to try and recognize this. There can be people who are central nervous system mediated bruxists, meaning that they're always going to be sliding side to side no matter what you do. They'll smash everything. So you've got to look at ways that you're going to try and protect their teeth and protect your work. And that's when realistically some form of guard is really justified. Somebody has a restricted envelope of function. You'll tend to see this as wear that is restricted to the front teeth, and often in class 2 div 2 cases where the front teeth are quite steep inclines, you'll then see wear associated with the pathway with the envelope of function. So remember, the envelope of function is the pathway that your bottom jaw follows when you eat and speak. We cannot change it, and if the teeth collide in this motion, you will get wear and tear. Simple solution, move the teeth out of the way. Allow the teeth to meet in intercuspation, but without that skiffing motion. A little bit of freedom, eccentric, ideally, is a great place to be. Caries, yeah, if there is loss of tooth structure, you need to identify if there's caries going on. You need to look at diet advice and maybe to get them to do a diet diary. And then things like perio. You may find, for example, that teeth are drifting. And if there is occlusal disease which is causing teeth to drift outwards, that's usually somebody who's a perio case that's lost bone support. And instead of the teeth chipping or breaking, it's the ligament that's giving way and the teeth are tipping outwards. And this is also often something that happens if the teeth are loaded off axis. So if you've got someone with freppatus and maybe a history of perio, you can only really expect those teeth to start to drift outwards as they try to compensate for what the muscles are doing as they push the teeth together. So yes, always try to be prepared for failure, and that's why it's so important to try and identify the most likely causes of failure before it happens. Communicate them, be prepared for them, deal with them when they come. More comprehensive cases. So, this is a pretty busy slide, but what this hopefully shows you is that, not everything is as simple as, is it A, is it B, is it C, let's do X, Y, or Z. When you have cases that are maybe more multifactorial, This case here has quite a lot of loss of tooth structure. There's a loss of vertical dimension. Those central incisors, I believe, were in the region of 8 millimeters long. The average central incisor will be about 10 millimeters long, and it will take 100 years to lose 1 millimeter of tooth structure in the absence of a destructive process. So keeping that in mind, this fella is not 200 years old, he's 28. And this is a lot of wear and tear for a 28-year-old. We identified a number of things here. He had acid reflux. You can see this by some of the cupping of some of those posterior teeth. There's caries. There was an element of single-tooth dentistry. Now, when you get the blinkers on, you see a problem in one tooth, your patient is demanding that you fix that problem in that one tooth, you will sometimes get yourself into a situation where you forget to see the whole mouth. And then that will invite failure of the work that you've done. And bruxism, of course. So this fella actually had quite a stroke of his jaw moving side to side. And you can see where related to the long motion, especially in crossover, that he was doing. And when we do this case and we decide how we're going to restore it, we've also got to think strongly about how do we protect it. So that's going to be a rehab case. And if you're not comfortable with things like full mouth rehabilitation, this is where you refer, you get a second opinion, you maybe get some guidance on how to manage such a case. And if you're interested in doing this type of thing, get it on your personal development plan. There are some fantastic teachers in the UK and beyond who can really help you understand how to manage restorative cases such as these. But if it's out with your scope or out with your understanding, you don't want to wade in and risk making those mistakes. So it's always important to seek further advice if you can. A little bit of a cheat sheet now. I'm going to run through this really quickly because it's a big, busy slide. But basically, if there is no posterior wear, if the canines are flattened and there's a little bit of chipping of the posterior teeth, you'll tend to find that a canine riser is a really good measure to try and unload structures and protect other teeth. If they have anterior wear only, and the posteriors look like they're near enough untouched, this is usually that restricted envelope of function, which you can de-restrict by doing either ortho, or you could increase the vertical dimension, which will move the bottom jaw backwards just a little bit. But truly, tends to be a case for both, if you can. If you see cupping of tissues plus or minus palatal erosion, this is often acid. It's important to look at dietary sources of this, especially if it's only cupping on the occlusal surfaces. But if there's palatal erosion, you'll often find that there's an element of reflux or maybe even bulimia or similar. So having that discussion with your patient is important. They might not even be aware of something. There could be a silent reflux, and that's where it's important to try and get a doctor involved. If you put a night guard in somebody who has reflux, and it's the reflux that's doing the damage, that acid is going to get under your guard and it's going to bathe their teeth in acid, and you're going to see much worse destruction. Again, important to identify causes of these things. Somebody has a class 3 skeletal bite and posterior group function. Remember that there's only going to be so much you can do without orthodontic surgery in this type of thing, and that can sometimes be a little bit of an extreme approach if somebody is otherwise fine. So making sure that those back teeth are strong and making sure that the assessment of their occlusion influences your restorative principles when you're working at the back is a really sensible approach. Somebody has a severe class 2 bite, particularly of skeletal origin, often somebody's got, a really big overjet and their teeth are hurting them when they're clenching together. This is sometimes one where you want to refer either for a specialist opinion or even for an orthodontic opinion as to whether or not there's an orthodontic approach or something like orthognathic surgery that person might be a good candidate for. If somebody has otherwise a fair skeletal profile and they have a deep overbite, increasing the vertical can be a good idea. This lengthens the muscles so that they're not able to contract as tightly, but you sometimes need to look at other means of trying to unload those muscles, and this is where certain orthotics can be quite useful. Crazing of teeth with locked-in syndrome or steep inclines preventing any lateral excursion. These people get stuck, they can't move side to side, and the tension just goes up and up and up and up as the muscles try and shift things around. Increasing the occlusal vertical dimension by and making smoother inclines can be a really good way to go. Or at the very least, you could perform, again, some form of guard, some form of orthotic that helps to reduce the forces that are going through things. If someone has full mouth tooth wear, which is sometimes the way, this is likely a comprehensive case, and you're often looking at multifactorial causes and more in the way of a rehabilitation to manage them. Refer if you're inexperienced, or at least seek advice, and if it's something you're interested in, have a look at the further training which is available. So, when you look at the mechanics of things, it's really smart to try and include this in all of your checkups if you can. You're aiming to predict and prevent fracture rather than simply react to it all day, every day. So if you just have a bit of a check during your examinations where you're looking at the slide left and right, forwards and back, and you watch which teeth interact, you can learn a great deal about how that mouth is going to behave or not in the longer term. And it's almost like a little bit of a crime scene investigation where you're looking at all the evidence that's there and you're piecing together a picture. This is part of whole mouth, holistic dentistry, not single tooth blinkered, I'll fix that and that will be fixed, and then find that it fails again shortly afterwards. So, in these more comprehensive cases, assess whether you're the right person for the task and whether or not the patient has the appropriate means to progress. A full mouth rehabilitation is an expensive thing to undergo. It can sometimes be quite onerous. You want to test things. There can be time involved in it. Nothing here needs to be a race to the finish. And the patient must take responsibility for what has caused the damage to their teeth so that they own the problem and they make changes based on that. You could do some really stellar, fantastic work for someone, but if they're not owning the problem and managing the things that caused it in the first place, you will not see long-term success, and you will only see an absolute train wreck when that reappears at your desk 10 years later. Remember, one of our most important roles as dentists is educating our patients, and anything you can do to make it easier for them to understand the issue so they may understand it fully in order to progress is so important. I take so many photos on a daily basis. I do write-ups for people. I email them to them in my spare time, but that's because I want my patients to be as educated and understanding as possible as what's going on so that they own their problems and they take reasonable measures with my help to try and make sure that things last as long as possible and we maintain healthy, functional mouths. I hope this has been helpful. Once again, I am Dr. Alan Matthews. I work at a practice called Integrated Dental Care in Edinburgh. And if you have any questions, please do get back in touch with me, and we can take things from there. If this has been of any help to anyone, and there's a subject you'd maybe like me to cover with a little bit more detail, get in touch, because I quite enjoy making these presentations, and hopefully it's been of benefit. Thank you.